Good afternoon, everyone, and thank you for joining the Curea Symposium, Recommendations for Wound Management in COVID Times and Beyond. My name is Sebastian Probst. I'm a professor of tissue viability and wound care at the University of Applied Sciences, Western Switzerland, in Geneva, Switzerland. I will be the chair of this session. I have the pleasure to introduce now the speakers of the session, Dr. Kirsi Isoherranen. She is a specialist in dermatology and allergology at the Wound Healing Center of Helsinki University Central Hospital. And she will talk about what is important when it comes to odor and exudate management, especially in COVID times. I will be the second speaker and will talk about clinical practice during COVID, lessons learned, and recommendations for the future. The last speaker will be Dr. Katrin Kühler. She is the Director R&D at Curea Medical. She will talk about the quick practical demo of curea technology versus foam technology. At the end of this session, we will have a Q&A part. Instead of answering questions after each session, we will address questions at the end of the symposium. It is unlikely that we have the opportunity to answer all your questions, but hope to address unanswered questions in the days following the conference. But before we start, I would like to present you the learning outcomes of this session. After this session, you are capable to discuss the importance of exudate management in COVID times and beyond. Then you can understand the services required to deliver an effective wound care service during COVID times and to discuss the characteristics and indications of superabsorbent wound dressings. It is now my pleasure to introduce Dr. Kirsi Isoherranen, who will talk about what is important when it comes to odor and exudate management, especially in COVID times. Kirsi, please.
Thank you, Sebastian, for your kind presentation. It is a pleasure to join this symposium, and I'm really happy that we have managed to do this with you all wound professionals. First, we can start with the definition of exudate, and we are used to define it like sentences like what is coming out of the wound, wound fluid, wound drainage, or an excess of normal fluid. And it's very important to keep in mind that wound exudate is produced by a really complicated interaction between wound etiology, healing physiology, environment, and compounding pathological processes. And exudate is not always only bad. It also assists healing by preventing the wound bed from dying out. We know that if the wound is too dry, it prevents wound healing. It also aids the migration of tissue repairing cells, provides essential nutrients, enables the diffusion of immune and growth factors, and also assists autolysis, what is very important in the cleansing of the wound bed. And here you can see a picture how exudate is produced. From the capillaries, there is a fluid leakage, and normally about 10% of this fluid returns to the circulation via the lymphatic system, and about 90% is reabsorbed into the capillaries. But when there is a wound, the fluid leakage occurs into the wound bed, and this is the basis of exudate. And we can define exudation by 4 points. And first is color. Usually when the exudate is clear or amber, we can talk about serous exudate that is considered normal. but sometimes it can also be associated with infection by fibrinolysin producing bacteria such as Staphylococcus aureus. If the exudate is cloudy, milky, creamy, it may indicate the presence of fibrin strands. Pink or red is usually due to presence of red blood cells. We can talk about hemorrhagic exudate. And green is indicative of Pseudomonas infection. Yellow or brown may be due to the presence of wound slough or material from an enteric or urinary fistula. And gray or blue may be related to the use of silver-containing dressings. Then consistency, there is high and low viscosity. High viscosity is usually due to high protein content that can be due to infection or an inflammatory process. And low viscosity, usually there is low protein content due to, for instance, cardiac disease or malnutrition. Then thirdly, odor. It is usually defined as unpleasant odor, and it comes from excessive bacterial growth or infection, necrotic tissue, dead tissue, smells bad, or sinus, enteric, or urinary fistula. And then last, the amount of exudate. We can talk about highly or moderately exudated wounds. And then we go to the next step. So wound odor, still very important, but often neglected in the wound assessment phase. And still it is cited by patients and also by professionals as the most distressing of all wound-related symptoms. And for our patient, this is important because it leads to social isolation, low mobility, depression feelings, feelings of guilt. And the malodor arises from a combination of factors, and most importantly, by bacteria, necrotic tissue, and high levels of exudate and poorly vascularized tissue. Still, there is yet no consensus on methods of assessment or management strategies of wound odor, so there is a clear need for further research in this area. And here in this table, we can see factors that influence exudate production. 4 main factors: wound healing states, local factors, systemic factors, practical factors. So there are many factors that influence, and those we must take into account when we assess the wound. The inflammatory states of normal wound healing usually has increased exudate production. And when the wound goes towards the end of the healing process, the wound shifts from the granulated one into a more epithelialized one, then the exudate amount decreases. And local infection or edema can also cause increased exudate, whereas ischemic wounds can be very dry and the amount of exudate is decreased. And when there are systemic factors like cardiac, renal, hepatic failure, exudate amount is increased, whereas dehydration leads to decreased exudate amount. And then practical factors, dependent edema, if the patient sits in a wheelchair all the days, there is increased exudate, and inappropriate dressing use can lead also to increase and decrease exudate. And with this table, I won't go into details, but just to show the newly published timers that gives addition to the traditional time model. Here, there is also included the repair phase in wound healing and also social and patient-related factors, which is very important. I think this table nicely shows that the wound patient assessment is very holistic. And the Exudate assessment usually goes with this moisture part, when you assess the moisture of the wound. And importantly, also in COVID times, if there is an unexpected change in Exudate, you must think whether there is a disease process that prompts re-evaluation. Usually, the most important thing to exclude is infection. And the amount of exudate is also partly dependent on the surface area of the wound. And increased exudate production occurs when there is wound infection, inflammation, as I mentioned earlier. And also I mentioned earlier this longer period spent with legs in a dependent position, e.g. in wheelchairs. And also if there is some problems with compression therapy, and if there is congestive cardiac failure or other peripheral edema. And as I am a dermatologist, I'm really interested in the significance of periwound skin treatment. There is some data and research on it, but still the treatment of periwound skin is not included in the usual wound treatment models. But in clinical practice, I see weekly that when we use corticosteroid creams, they really have the anti-inflammatory potential, and they heal the wound with dressings when they are used together. Of course, you need also these absorbent dressings, but you can get miracles within 1 week if you use corticosteroid creams in the leg with venous insufficiency, good absorbent dressings, good compression therapy. The situation can change dramatically within 1 week. And the topical corticosteroids we use are the typical ones, mometasone, desonide, betamethasone. The problem with these is that they usually need a prescription, and that's why we also need doctors that are interested in wound healing. And with this table, you can see a Taiwanese report on telemedicine algorithm for wound care during COVID-19. The Taiwanese are very advanced in the protection and COVID testing, but the main point with this table is that with all telemedicine consultations, you should always also be aware about the acute processes like acute infection, acute ischemia, and then you should think how the patient can access to a multidisciplinary treatment to specialist evaluation. So to take this into conclusion, I think that during COVID-19 is extremely important that the wound diagnosis is exact. And this can be problematic when there is first-time consultations. Then the optimal situation is that you have a healthcare professional on the other side also, and you can guide how she or he can get the exact wound diagnosis. And the main wound diagnoses are venous, arterial, mixed venous arterial, lymphedema, pressure, diabetic, and atypical. And always use compression therapy in leg ulcers when you have excluded arterial insufficiency, no matter what is the diagnosis. Not only in venous leg ulcers, also in atypical ones, in pressure ulcers if there is no arterial insufficiency, in the diabetic ulcers. And of course, we must have patient adherence, and that is that we must inform the patients exactly. We must inform about leg position, nutrition, pain treatment, and signs that warrant prompt consultation, that the patient must call us. And of course, last but not least, appropriate dressing depending on exudate type and amount. And during COVID times, it's extremely important that the dressing has enough absorbing capacity, because the dressing changes may be fewer and it has a good capacity to retain fluid and also to combat odor when the patients are more in home settings. And finally, I want to show a problematic case of our clinic, a 73-year-old man living in a senior house using wheelchair, so not moving so much, also Alzheimer's disease, and venous leg ulcers since 2015, and no arterial disease. And there was a component of livedoid vasculopathy also, that is a thrombotic disease of the small arterioles. And for that reason, he has also anticoagulant therapy. And the main treatment is, of course, compression therapy and good absorbent dressings. We tried bunch grafting in autumn 2019, but nearly all bunch lost. And during COVID epidemic, we treated him with weekly calls, with photographs, with my tissue viability nurse, as we had the exact diagnosis. So I think in that case, a tissue viability nurse is the right and most expertise person in assessing the exudate and the treatment of the wounds. And the situation was in April like this, that he had moderately exudated wounds in the toe area. And I think personally that this is a very challenging situation for compression therapy. And also in the malleolar region. And the advice was that mometasone liniment, we have the name Elocon in Finland, in the periwoon skin, absorbent dressings and compression therapy. And in the end of April, exudate and odor was increased. And my tissue viability nurse recommended that the mechanical debridement should be done more probably, more absorbent dressings, and also pointing the importance of compression therapy and more leg elevation for this patient sitting in a wheelchair. Unfortunately, in August, we were in the same situation, perhaps because the lack of expertise of compression therapy with the senior house nurses, perhaps that, we don't know the exact reason. And the next phase might be transmetatarsal amputation, because the patient sits in a wheelchair, so he's not using his legs. And I was thinking that perhaps for the better quality of life, this would be a better choice for him, even if it sounds awful. But this was just to show about the problems we have. We know how this should be treated, but when we cannot treat the wounds daily or 3 times a week, the tissue viability nurse cannot go there, then we must rely on the expertise of the senior house nurses. And lastly, I want to thank you for your interest. And personally, I think time does not heal all wounds. We need good strategies and good wound products. Thank you.
Thank you very much, Kirsi, for a very interesting and informative session. Please be aware that we will answer all your questions at the end of this session. I will take over now, and I will talk now about clinical practice during COVID, lessons learned, and recommendations for the future. As we all know, in response to the pandemic, some hospitals have closed their wound centers, either because they have misclassified the service as non-essential, or they have limited visitors and outpatients from entering in the hospitals. That means those outpatient clinics were closed, and additionally to this not having access to wound clinics, there was another problem. That means the patients had to apply the containment measures issued by the local governments. That means they had to stay at home. That means with staying at home, they had a reduction of their physical activity. And as we know, and as we heard also from Kirsi, we had to, for example, for a patient with a venous leg ulcer, they have to walk to for their muscle pump, but also they have to be in their chair to rest a little bit. This was okay for them, but the other problem is with our patients, wound patients, we know they have about 3 to 4 comorbidities. That means these patients are high-risk patients to get infected with the COVID and to develop extreme complications. So what is the goal of the treatment during this pandemic? We want to offer a maximal therapeutic benefit with a minimal exposure of the patients and even of the providers. So how can we do that? And what does the literature say? Here I present a survey made in Switzerland. This survey was done 4 weeks after the implementation of the lockdown. In this survey, they asked 1,537 Swiss residents with a mean age of 46 years. I know this doesn't represent our wound population, for example, when we have the venous leg ulcer population with a mean age around 70 years. But it is interesting that 68% they didn't have access to healthcare system, or they weren't allowed to use the healthcare system. If we look to our wound patients, that means we have a delayed diagnosis and also a delayed treatment. Only 18% indicated they kept their medical appointment. That means they could go to their GP or to a center that was still open. Other literature demonstrates from here, a study from the US demonstrates that there was a 40% decrease in wound center visits in a data set from the weeks 12, 13, and 14 in 2020 versus 2019. Another study from Italy demonstrates that the prevalence of gangrene was significantly higher than in 2019. That means in 2020, we had 64% of the patients in this study represented a gangrene versus 29% in 2019. The proportion of patients requiring an amputation was also significantly higher. That means in 2020, we had 60% of these patients requiring an amputation, and in 2019, only 18%. Going back to the settings, as I already said, and you can see in this graphic from Rogers, from the pre-pandemic to the pandemic model, the hospitals, they were mainly used for COVID patients. So that means all the elective surgeries and mainly the wound centers, they were closed because those wound centers are mainly in the hospitals. So they were asking to do the wound care, wound treatment off-site, but most of these centers here, also in Switzerland, were closed. So that means everything went back home. That means the nurses had to go to visit the patients at home, and that means they have to provide home care or telemedicine. I will now talk about telemedicine and show what we experienced during the COVID times. You heard already in Kirsi's presentation from the telemedicine model from Taiwan, and I will show you what kind of telemedicine models we can have during COVID times and that are used within Europe. You can have the real-time telemedicine. That means a physician, a nurse, is on the computer and is talking live with a patient. This is either through with a community nurse. That means the community nurse is with the patient, or it is the patient itself who is using his phone or his computer. This was seen mainly, and in France, for example, this was used for mainly there. The tele-expertise is when the patients, or mainly nurses, from community nurses, are sending their questions with the picture of the wound, for example, to an expert center. And the experts, nurses and physicians, they are replying to these nurses or even also to patients. What we experienced in Geneva, that in one outpatient clinic where we have telemedicine, the nurses, they had to go to the patients at home to take care of the wounds, and the telemedicine service had to be interrupted. The telemedicine service had to be also interrupted with nursing homes, because this was not a priority for nursing homes. They had other problems to solve, and therefore they interrupted this service. We have also the remote patient monitoring that refers to the use of specific technology to facilitate interaction between the clinician and the patients at home. Let's see what happened at home. One element that was very important is the self-care. That means patients had to take care of their own wound, especially then when they were afraid that somebody is coming, or they didn't want to, that a healthcare professional is coming to take care of the wound. This means that we had to have a good self-management of these patients. We have to guarantee that they had enough dressings, that they know what kind of dressings they have to use. How do they have to change the dressings? And what were the signs of, for example, infection? What does it mean when dressing is saturated with Exudate, for example, or what does it mean when we have odor? This means we had to educate the family and the patient. This is most of the time that happened already before the lockdown. That means during the constant patient education, the patient was aware what kind of dressings were used. The only problem was that the patients had the used dressings at home. The other element is that the community nurses passed at the patient's home, but that was sometimes a risk for the patients and also for the communities, to nurses, to get infected by the patients. But now you have to imagine all the patients from the outpatient clinics were sent at home, and the community nurses had to take care of these patients. There was a lack of staff. That means not all specialized nurses could take care of all the patients. Additionally, the problem was also the time management, that patients had to wait till a community care nurse passed and was doing the dressing change. As I already said, were there enough wound care specialists that were taking care of the wounds? Here, our experience shows, unfortunately not. That means registered nurses passed and did the wound dressings as good as they could, and especially they had to provide the dressings. Some of them, they were not, they had not the knowledge to use the advanced wound dressings. I would like to show you one example of from a patient who we followed in the outpatient clinic and who came back after the lockdown. As you see, the first picture, you see the wound, the leg ulcer. That picture was taken on the 7th of February. So we introduced all the different kinds of treatments. We were looking that we have a good exudate management, and the patient got a compression therapy. Then you see March 19th, the wound got smaller thanks to the therapy we applied to this patient. And then the patient was sent home, and this patient took care of himself. Here you see the last picture, you see that is taken on the 23rd of June. You see the wound got bigger, even the patient developed a second wound, and you can even see that there we had to do a debridement because of the fibrin that was in the wound. So it took us longer now to take care of this patient and to got back to the stage we were on February 7. So what are the recommendations for the future? Something that is very important, that you always keep the contact with the patient. That means only a telephone call or asking the patient, if the patient doesn't want you to come at home, that he sends pictures, photos to your hospital, and that you can have a surveillance from the hospital. The literature says it's not bad if you can have contact with the patient in a lockdown, for example, twice weekly. So during this assessment by the phone, you can ask all the different kind of signs and symptoms, and the patient will tell you what he presently feels and what he can presently see, or you can ask him to show his wound. Through this teleconsultation, for example, you can educate the patient, or even between the lockdowns, you can educate the patient and show him how to perform wound care, how to do a dressing change. Something that is very important, and we heard that from Kirsi during her presentation, is the dressing selection. So that we know what is the surrounding skin, how much exudate do we have, and especially how many times do the patients have to change their dressing? What does it mean when, for example, a superabsorbent is saturated. One thing that we have introduced in Geneva, and that was also with success, that we provided a single dose of packages. That means we told the patient, this is number 1, this is number 2, and you have to put this dressing first, the other dressing afterwards. That means also that if there is less confusion, which dressing has to go where when you have only the packages delivered. Another element that could be helpful for future service provisions within the pandemic is to provide patients video instructions how to change dressings. This can be helpful then, more helpful than giving the patients only some verbal instructions. I would like to give you an overview of a study we just completed about the wound size reduction with superabsorbent dressing and a foam dressing. On the left-hand side, you can see the wound size reduction in square centimeters from the superabsorbent dressing and the foam dressing. The superabsorbent dressing has a significantly higher, faster wound size reduction than the foam dressing. This means we had a better exudate absorption. The same graphic you see with the percentage where the superabsorbent dressing has nearly a 30% faster wound healing, that means a wound size reduction, as the foam dressing. And as I said, we had a much better wound exudate absorption. When we go to the conclusions, so we were looking at problems we faced during the COVID lockdown, and it showed that that impacted all wound patients in any ways. We had a risk of more amputations because of this sudden interruption, and we saw also that patients got more isolated because they were not allowed to go outside. So there was this shift between the hospital and the home care setting. That means we need to have enough nurse specialists that are going home to patients, or GPs that are well, that have an education in wound management. I could show that telemedicine could be a possibility, but sometimes it's not possible because of the circumstances. We need to increase the self-management of our patients, and we have to show patients how to use the dressings and what the signs are to go to a physician, for example, or to call a specialist clinic. What I found very interesting when I was reading the literature, some authors, they cite the pandemic impacts the healthcare system and for at least 18 months. So we have to be prepared that we are having another lockdown, and that this will continue till for example, next spring. Here you have the references, and thank you very much for your attention. Now I will go over to the last presentation and would like to introduce Dr. Katrin Kühler, who is the director of the R&D at Curea Medical, and she will give a short practical demonstration of the curea technology versus foam technology. Please, Katrin.
Thank you very much for the introduction, Sebastian. As we heard before, exudate management, especially in COVID times, is more important than ever as patient care is getting more complicated. One thing that is extremely important during COVID-19 is the selection of an appropriate wound dressing, depending on the exudate type and amount. Fluid handling capabilities can benefit patients and clinicians in the COVID situation, where wear times of dressings might get longer as a result of patients being scared to obtain care or care not being available due to resource limitations. So what I do now is to give you a demonstration of how the Curea P1, a super absorbent sodium polyacrylate containing wound dressing, handles exudate in comparison to one of the most used polyurethane foam dressings within the wound care market worldwide. Therefore, I will show you the two dressings of 10 by 10 centimeters. On the one side, we have the polyurethane foam dressing, and on the other side, the Curea P1 dressing. I prepared 2 beakers, each filled with 80 milliliters of test fluid colored with a red food coloring E124. 80 milliliter corresponds to 2/3 of the specified maximum absorption capacity of Curea P1. So I will now pour the liquid in both dressings to see how they actually manage that amount. Of course, in the rarest cases, this amount will come out of a wound this quickly, but this is just a lab demonstration and not a clinical setting. I will turn the dressings around and allow them to absorb all the fluid they can. You see, there's still some excess fluid here in the petri dish of the polyurethane foam. Now I will just remove the excess fluid into separate beakers to better show you the difference between the two dressings. As you can see, there's actually quite a bit of fluid that wasn't absorbed by the polyurethane foam, whereas the super absorbent dressing just left nothing. And now to show you the aspect of retention, I have to rearrange my lab setting a little bit. To provide a moist but not wet wound care environment for the patients, and especially in cases where the compression therapy is indicated, it is very important that an appropriate dressing can actually also hold back the absorbed fluid. So what I am going to do now is to put pressure on both wound dressings using a standardized weight of 5 kilograms, which correlates to a pressure of 46 millimeters Hg, which is classified as compression level 3. So I will start with a foam dressing. The foam dressing is placed on a grid. Then a Perspex disc is placed as interface layer on top of it. And then the weight is placed on the wound pad. And the liquid that is not firmly bound is also easily squeezed out of the dressing. So now I do the same with the Curea dressing. And here the majority of liquid that was absorbed before is bound within the core of the dressing. So the dressing is retaining most of the absorbed fluid, in total 67%. So now I put the dressings back and the equipment away. And there's also clinical evidence that bacteria and exo and endotoxins abound within the core of the dressing, and that you won't get any reinfection of the wound caused by the dressings. The same thing goes with MMPs, and that, of course, is important in chronic wounds where the MMP level is far too high compared to acute wounds. And now to show you again the results of the absorption and retention test, I will mix the two liquids together of the absorption of the retention test. And you see there's some amount of fluid which wasn't handled by the polyurethane foam of about 50 milliliters. We do also know that the quality of the periwound area and the edges is impacted by the dressings. So I've taken here a piece of filter paper and just touching the surface of the dressings. And you see here on the foam dressing, that surface will still cause the periwound to be very wet. I try the same thing on the curea dressing. And you see it will not create or leave any moisture on the skin, while at the same time there is some moisture support due to the contained cellulose to keep the wound moist. But it will not wetten the wound, it will not wetten the edges, and will therefore prevent maceration. So I hope I could help to better understand how a better exudate management can improve the wound care situation in COVID times and beyond. So thank you very much for listening, and I will give back to Sebastian. Thanks.
Thank you very much, Katrin. It is very interesting to see how newer technologies like curea can provide improved benefits for clinicians and our patients. I would like to thank you again to our speakers. We have now time for a few questions. As mentioned initially, we will not be able to answer all questions, but hope to address unanswered questions via emails in the days following the conference. The questions that came in were, what is your opinion the main problem when it comes to exudate control?
I think the main problem is if the dressing surface keeps wet, as Katrin nicely showed us, because it does like maceration in the periwound skin. And also if you put some compression, that is very important in all venous leg ulcers, if there is a leakage of the exudate from the dressing. Those 2 points, I think, in my opinion, are the most important.
Exactly, I can underline this. This is really the biggest problem we face in clinical practice, that when we have our patients with venous leg ulcers that have a lot of edema, and then we have to put dressing on that is absorbing all the exudate under compression. Thank you.
And I would like to add that
yes,
there are different types of exudate. So we don't have a standardized fluid. So we have different etiologies.
This was also nicely demonstrated by Kirsi's presentation. Now, another participant is asking, great demonstration of the differences regarding foams by Dr. Kühler, but what are the differences of curea wound dressings regarding other superabsorbent dressings?
Yes, I would like to answer this.
Yes, thank you.
The various polyacrylate-based wound dressings sometimes differ very significantly from one another. So this can be due to a number of factors. So firstly, there are the raw materials used and the production of the core material. So then there are the materials of the dressing envelope. So these different kind of factors result in differences in absorption, capacity, haptics, wound contact, and cleanliness of the dressing. So, for example, the design of our supercore results in its ability to bind germs and absorb blood. And the materials on the reverse side, so the BTBS, provide a sterile barrier for the curea P1 and the curea P2 wound dressings, which protects the patients as well as the user. And the materials on the wound side also determine various effects. So a non-woven, as on the curea P1, creates a soft debridement, while a 3D polyethylene film, as on the curea P2, guarantees an adhesion-free wound contact. Yeah.
Okay, thank you very much. This is a very nice illustration of the different kind of superabsorbent dressings. We got another question from a participant, and this participant is asking, when we have malodorous wounds, and that we face a lot in clinical practice, we normally use antimicrobial dressings, while I know others use carbon dressings. What is your take on this issue? I will hand first over to Kirsi. What do you think about this?
Well, I think that I would prefer carbon dressing if there is no infection, because we should not use antimicrobial dressings too much. So if there is no infection, I would firstly use carbon-based dressing.
Yeah, I totally agree. This is mainly a lot misleading. The antimicrobial dressings are used too much, and they are indicated for infected wounds. And at the moment, it's also a big discussion in several countries about the reimbursement of antimicrobial dressings. And we use also, if we have malodorous wounds, carbon dressings. We have another very interesting question from a participant who is asking how long periods you can use corticosteroid creams in the periwound skin. You mentioned that, Kirsi, during your presentation. How long can we apply that?
Yes, thank you very much for the question. Usually we use corticosteroid cream when the wound is treated, so it can be like 3 times a week. And when you have compression bandages, they like potentiate the effect of the corticosteroid creams. And usually it is enough to use 3 times a week for 3 or 4 weeks. And the typical scheme is also that you can use it daily for 2 to 3 weeks, and then have a pause also for 2 to 3 weeks. So the pause is as long as you have used it. So there are different regimens, but I would also like to highlight that you should not be afraid of using corticosteroid creams. I heard a lot of times that you should not apply corticosteroid creams over wounds. That's nonsense. You can use it, and usually it leads to good results.
Thank you, Kirsi. This is a very nice explanation. And we can take only one question, and there is one what were the difficulties of implementing telemedicine in your context? I will take that question. The implementation of telemedicine can have several difficulties. I can tell you that what we experienced it in Geneva, that we were implementing that with nursing homes. That means that firstly, we have to have the same software. Some are using Android, some are using iOS. Then the other problem was the internet connection. Not all wards had a wireless internet. And also the problem was that the nurses and the physicians, they had to use this new technology. So that means you have to teach them, you have to show them step by step what they have to do. Additionally, we saw that the problem was delivering products. Here in Geneva, you can order now single dressings. That means if you have an infection, for example, and you need an antimicrobial dressing, so we can send a couple of antimicrobial dressings, or if you have a wound with odor, then we can send a couple of dressings with carbon, for example. But the other problem is, of course, that sometimes it's the communication between the different players. That means the physician has to prescribe dressings, they have to be informed. So that means it's all the different kind of disciplines have to work together, and it has to go everything in on one time. If you want to hear further discussions, or if you have further questions about telemedicine, there are different kinds of sessions during the conference where you can get some more information about this topic. There were also a number of questions, especially linked to the curea dressings. If you have further questions, I recommend that you approach the Curea medical virtual booth or visit the Curea website under www.curea-medical.com. This brings the symposium to an end. We hope you had enjoyed it and have picked up something that will be useful for your clinical practice. Thank you very much to all of you for your attendance. A special thank you to the speakers and to Curea Medical for setting up this session.
And thank you, Sebastian, for excellently guiding us through this symposium.
Thank you very much.
You're very welcome. So that's it. Goodbye. Stay safe and see you next time. We hope to see you as possible in person at the UMA 21 in Paris. Thank you and goodbye.